We are good to go.
Okay, thank you so much. Good evening, good morning, good afternoon, everyone. Welcome to the first Fresh School Health and Nutrition webinar for 2019. My name is Mohini Venkatesh and I'm from Save the Children. As many of you know, the Fresh webinars are a series of monthly presentations on school health and development in low and middle income locations, jointly organized by Fresh partners. This month, we're celebrating the first ever International Day of Education, which took place on the 24th of January, when education advocates from across the globe emphasized the role of education in peace and development. As noted by UNESCO, without inclusive and equitable quality education and lifelong opportunities for all, countries will not succeed in achieving gender equality and breaking the cycle of poverty. Recognizing that education needs to be holistic, Save the Children, which began its first school health and nutrition technical unit over 20 years ago, moved this element of its program over to the education department over a decade ago. Leading the unit on school health is our senior director, Sung Lee. She's been with Save the Children for over 15 years and was instrumental in the transition of school health and nutrition within education. Prior to Save the Children, Sung was with the World Bank for 6 years, providing technical support on school health with the sector's key players, including Don Bundy. Sung is joined by her first staff and the person who started as the first staff of the technical support unit at Save the Children, Natalie Roshnik, for the webinar. I will now hand it over to Sung and Natalie, if Natalie's on the line, to talk about Save's 20 years of experience in integrated school health. And before I do, a quick reminder to keep yourselves muted through the presentation. And if you have any questions during the talk, please feel free to type them in and also introduce yourselves in the chat box. Over to you, Sung.
Thanks, Mohini. And thanks everybody for allowing me to sort of walk down memory lane. It's incredible that school health and nutrition programming has been ongoing at Save the Children for 20 plus years. And I was just chatting with Andrew Hall, who's also on the webinar participant list, and how he, with several different people at Save the Children, helped start that program. So there's a long history and a lot of people who are dedicated to school health and nutrition, and it's great to see that there are so many people who are still following the progress made and the just transitions and the growth of school health and nutrition, not just at Save the Children, but globally. But it's really good for me to be able to speak specifically about school health and nutrition at Save the Children. And again, it's this is a little bit of a memory lane trip discussion. But as Mohini mentioned, yeah, somebody's typing. Yep. As I've been with SAVE for 15 years, and then before that with the World Bank. But while I was at the World Bank, I actually had the pleasure of visiting the program at Save the Children. So I've seen the 20 years of progress at Save the Children. Next slide. Yep. If there are people who have not muted themselves, could you mute yourself, please? I'm getting some background noise. So just to remind you that I work for Save the Children, whose mission is to actually work for children's right to survive and to be protected and to participate and to learn. I also wanted to highlight the fact that it is the 100th anniversary of Save the Children. And over the course of this year, we will be celebrating different different interventions that Save the Children have been supporting for the rights of children over the 100 years. Sorry, again, there's a lot of feedback from people who are not muted. You could mute yourself, please, Gim and Shupada. That'd be really helpful. Yes. Just quickly, the timeline, just to point out that we had started some programming in 1998 in Bangladesh, Malawi, and Mali. Again, we'll talk a little bit more about the programming at that point. But this was a couple of years before the 2000 Fresh framework that was launched at the Education for All conference in Dakar. So it's Save the Children was testing out school health and nutrition programming to be able to be part of that quality education that is part of Fresh framework as part of Education for All in Dakar. And then slowly from that 1998, we were growing from 3 countries to more countries taking on the school health and nutrition using different funding sources in different contexts. Over the years, we've grown to many, many countries. Another highlight is 2009, about 10 years ago, Save the Children, it was transitioning from separate organization into one global organization. So when I talk about 1998, we were working with Save the Children US, but that is no longer a distinction. We work in a global organization where we are trying to implement quality education and health programming throughout all the countries where we work in. So that started in 2009 with the transition to one global organization. And again, in 2015, when the SDGs were set, the Fresh framework was reaffirmed at the education conference in Incheon. And then now this is the year where we are celebrating the 20th year of school health and nutrition at SAVE, and then the 100th year of Save the Children in general. Next. So I wanted to talk a little bit about the program in Mali. As I mentioned, I actually had the pleasure of visiting the program in Mali. I wanted to highlight that this was a pilot program, and what some of the things I got to see are very precise, different activities we were trying. For example, I saw teachers being trained to actually deworm and monitor children as we were directly deworming them, and creating new monitoring forms for the teachers to use. I saw Natalie Roshnik training the teachers to use child-to-child methodology and working through the steps to make sure the children understood how to collect data and use that to actually share and share information and do health education messaging to other children. So these are activities that I actually got to see in Mali in 1998. And I want to point out, this is 20 some years ago, and we were still developing the Fresh framework. But if you look at the different interventions, they do follow those 4 critical pieces: increasing services, in this case, actually delivering deworming directly, working with teachers and children to deliver health messages, health education, working to improve water and sanitation in schools. So one of the things I noticed that we were struggling with different ways to keep clean drinking water in the classroom, and looking at clay pots and plastic pots, trying out different methods of actually trying out how to have clean and drinkable water in the hot Sahel in Mali. And I remember these things because I was actually just visiting, but I was struck by how we are trying different methods and trying to figure out how to make things work. And then finally, the last bit is really working with the Ministry of Education at the local level and the PTAs and parents and teachers to get them included in the project. So this, again, is 20 some years ago. The Fresh framework hadn't been officially launched yet, but within the business, we all kind of understood there are 4 critical pieces, and we were working with those 4 pieces even in 1998. I'm going to stop myself right here and then see if Natalie or Andrew Hall, who are also online, if they have any comments and talk about what it was like starting these programs 20 years ago. And all those people who've just joined us, can you please mute yourself? Thank you. Except for Natalie and Andrew, if you guys want to say something, please jump in.
Andrew?
You go ahead, Natalie. You have the lot. I would have recruited you to go out to Mali back in 1998. So.
Well, I was just, and I don't know, I don't want to be like this sort of long, but I just remember coming out of my master's in public health nutrition from the London School of Hygiene, thinking that I knew so much and I was an expert. Well, I don't know if I thought that, but I certainly thought I was more than when I arrived in Mali. And Andrew interviewed me for a 10-day literature review, I think you wanted me to do, and found out I spoke French, and then said, actually, why don't you go to Mali and help start up this school health and nutrition program? And now it's sort of 20 years later. Oh my goodness. So, and I guess, yeah, arriving there, thinking that maybe I knew all about nutrition because I'd done a 1-year master's course, and I realized very quickly that I knew nothing at all, and sort of got thrown into, you know, doing big baseline surveys to collect, you know, data on worms and feces and iron, hemoglobin, and all sorts of stuff. So, and calling Andrew, because in those days there wasn't any internet down in the zone, so sort of I remember calling Andrew from the post office and spending so much money on one phone call to understand how to sample the children and all of that. So that's my memory lane. But I ended up spending 2 years in Mali, and it was a huge learning curve. But I think what was exciting, and you know, throughout at least my years in SHN, is that it started off, you know, I think we did a lot on deworming and iron supplementation, vitamin A supplementation at the start, but you know, then moving into HIV/AIDS prevention and so many different topics. And I guess one of my big, you know, great moments I preferred it, while, you know, one of the activities I liked the most, and I think I saw Claire Hanbury that was on the phone as well. Is she there? Is that right? Because when you mentioned the child-to-child approach, I think one of the most satisfying things we did, but it was very small scale, is sort of really teaching children to take action in the community and change behaviors in the community. And I think still until today, I think that's a very exciting area for school health and nutrition. So maybe I'm going to pass it over to you, Andrew, to say something more.
My memories are fading, I'm afraid, with the years. I can't really add a great deal. But I think the FRESH framework was actually derived from experiences of Save the Children. It wasn't the other way round, really. I think everything that Sung just said about school health nutrition in Mali was incorporated into FRESH because of the experience of Save the Children in those very early days, and collaborating in research as well. This is again another recollection, but I designed a randomized trial. We were interested to see whether teachers could actually give iron supplements to children in school. So I designed this trial, and Natalie then went ahead and did it and completed it, and it was published. And it's one of the references I cite regularly now to show that teachers can be trained and are willing to deliver micronutrient supplements as well as deworming treatments. So I think for me, that mixture of programs and an interest in research and recording what is done has been particularly fruitful. And I think over the years, we published 8-10 papers on various bits of work that Save the Children have done in school health and nutrition around the world. I'll pass back to Sung now.
Great, thank you. And I think the next slide sort of highlights what we've been talking about. Maria, next slide. Is it me? Yeah. Next, yeah. So just a quick slide to show that one of the key things about setting up a new program is that we did go in intentionally to collect some evidence and be able to show results. And thanks, Andrew, for highlighting that we Save the Children did look into creating new evidence and gathering the data so that we can actually have policy that's based on good experience. And so these are about 10 years into the program, looking at some of the changes we were able to record because SAVE did invest in gathering baseline data and then actually finding results. Next slide. And then I'm going to take this. Next slide, Maria. Or is it me? Yeah. So I wanted to actually talk about the successes and innovations. And I think the deworming piece is a really interesting piece over the 20 years that things I've seen change. But I did want to take an opportunity to also shout out to Claire Hanbury, who's also online, and she was instrumental in helping, as Natalie pointed out, working on the child-to-child methodology, actually looking at how we deliver health and nutrition messages that can be carried on and that can be more sustainable. Claire, did you want to add anything at all? You're muted if you want, and I've not given you a heads up before, so if you don't want to say anything, it's understandable.
Hi, Sung. Yes, it's Claire. Yeah, thank you very much, and hello, everybody. Yes, I feel very much sort of a part of Save the Children's team. I don't know if you feel that way, but it's very nice for you both to mention me and my contribution to this. I think there's lots more to do, and we're trying our best to do some work with Save the Children and others, slightly simplifying the child-to-child approach, but sticking to its basic principles. So yeah, thanks a lot. I don't want to take your time.
No, and I think near the end of the webinar, I will mention some of the continuing challenges. I think behavior change is a revolving science, art, and it's always a challenge. But going back to the slide, I did want to highlight some of the changes I've actually noticed through Save the Children. And these are sort of the big successes and big changes and continuing work we're doing. So next slide. Next slide, Maria. Yeah. So this is a classic picture that I like to share just because it does in one picture show you, how much a simple activity of deworming has an impact on sheep and similar impact on children. And I think we talked about the fact that we can, okay, somebody's typing. Can you mute yourself, please? Sorry. So it just shows you how a simple act of deworming can have an impact on sheep and also on children. And it's something that over the 20 years, I think Andrew and Natalie mentioned the fact that we worked with teachers directly, having them deliver the deworming tablets. And Save the Children actually purchased the drugs and delivered them to schools to be able to actually deliver them. That was 20 years ago, and things have changed. This is the concept has been proven to be effective. Parents and teachers welcome the opportunity to have deworming happening in schools. Teachers need some training, but they can do this. They have monitoring forums, and there's now national programs that ask teachers and health workers together to deworm children. So over the years, 20 years ago when Save the Children started, we had to deliver those activities directly. 20 years later, we should not be, as an NGO, we should not be delivering any of the deworming directly, but rather helping the Ministry of Education and Health work together to make sure that the schools where we happen to be are actually delivering those programs, and they're national programs, and then international pharmaceuticals who are donating those drugs. So I think this is an example of the big shift from us purchasing drugs and training teachers directly to where now we should not be purchasing drugs. We should be supporting the teachers and the ministries to deliver the deworming programs. But as an NGO, we are there as a support, no longer actually delivering it directly. And it just shows you how effective the pilot programming was. And over the years, there was enough proof, enough partners, and enough advocacy to say this is an important intervention that has an impact on children and that can be delivered easily in collaboration with teachers and parents and the different ministries. And that it is, again, a national, internationally recognized program, and there are a lot of partners. And I just wanted to highlight that's a huge piece of that change I've noticed. And related to that, the next slide is another sector, WASH in schools, that has also seen quite a difference. I would say when I was visiting schools 20 years ago, I would be visiting schools where the teachers and the Ministry of Education staff consider classrooms their domain. Anything beyond the classroom and the principal's office was not part of the school. So school plans did not have these three pieces: water or sanitation or hand washing. That was not part of the Ministry of Education's domain in many, many countries and schools I visited 20 years ago. But things have changed. We have progressed to the point where I would be shocked to find any ministry of education who deny that school-age children need WASH in the school facilities. And that has changed and translated into SDGs, where as a goal, we now have a goal where we want basic WASH services in all the schools by 2030. So I do think this is one of the big changes I've actually been able to witness, going from schools where, again, water and sanitation was not considered part of the Ministry of Education's domain, but now it is part, and we have global goals to make sure that all children who are attending school have access to basic drinking water, sanitation, and hand washing. Next slide. And we actually have definition of what we mean by that. We, basic services actually mean having water that's there and available when we're visiting, not just pipes that are no longer functional. It has to be functional when we are monitoring these. So we have now globally agreed on monitoring definitions about what we mean by WASH in schools. Next slide. And we can see that JMP is the joint monitoring program, UNICEF and WASH. Until recently, their collection of data was focused on households. With the new SDGs, there is now an effort to collect information about the facilities in schools. So this is the release of the baseline that was done a couple of years back. We still have a long way to go, but the fact that there's now monitoring, UNICEF and WHO are using EMIS data to see whether schools have the basic water services. I think that's another huge change in school health and nutrition. It's no longer acceptable to just build school classrooms. We actually have to think about what children need when they're in schools, and to be able to actually learn. Next slide. And related to that, I just want to point out that WASH is about, these are two latrines. One's obviously not very useful, and then the next one is a useful and actual functioning one with the hand washing station that's underneath the tree that you might not be able to see. Next slide. Similarly, you have two water stations, hand washing station, where one you can actually, there's water and soap, and the other one there's no water, and then the children can't actually reach it. So what's the difference? Next slide. There's an emphasis now on operations and maintenance. Again, 20 years ago, schools weren't building them, and then they were recognizing you needed to build them, but it was all about the infrastructure, and they would be latrines that were built and left to no longer function, or water points that money was spent in the infrastructure, and then 2 or 3 years later, they were no longer functional. And it's to look at and see what, why are we investing in so much in infrastructure if it's not functioning? And to look at the operations and maintenance of school health, school wash activities. So again, that's another huge change that's happened over the 20 years, going from nothing to some infrastructure, and then recognizing infrastructure needs to be operational, and that requires actual careful planning of operations and maintenance activities. Next slide. So this is a slide about oral health. I'm sure I have pictures somewhere of children brushing their teeth, but I just wanted to highlight that, again, 20 years ago, we didn't talk about brushing teeth. And it is now an integral part of many of our programs. And this came about partly because there was recognition children were missing school because of oral health. And I think a lot of the school health and nutrition, it comes from a health and nutrition angle. And there was a lot of focus on WASH and nutrition and deworming from a health point of view. And I would say that oral health was something that was not highlighted. But when you start talking with the education folks and talking to children and parents, there was recognition that in many countries in Asia and Latin America, children were missing school because of poor oral health. And I think, again, 20 years ago, it was not highlighted, but I would say currently most programs recognize that a basic lesson on toothbrushing and better nutrition for oral health is an integral part of school health and nutrition. Next slide. So I've talked a lot about different changes that have happened, and I wanted to also talk about innovation that is about malaria control in schools. So there is about 10 years ago, sorry, I'm getting distracted by people not muting themselves. We recognized in Malawi that children of school age were dying from malaria. And this is something, again, 20 years ago, we weren't focused. I think the changing nature of malaria rightly, the public health was very much focused on under 5 and in pregnant women and trying to prevent malaria among the most vulnerable. So the school age children were not a population that the malaria community had focused on. But because we were working in Malawi and we were tracking the health and death rate among children of school age, and we noticed that malaria was actually one of the top causes of death among school age children in Malawi. And so this is where again, it wasn't a huge population, and school age children are mostly healthy. So there weren't many children dying, but the few that were dying were unfortunately dying mostly from malaria. And so we actually looked and see what can we do about malaria in schools for school age children in a country like Malawi, where really the health services and health systems were very weak, and the schools were overcrowded, and there were many children in the schools, and we had success of delivering deworming tablets due to the school systems. So we looked to see what could we do to actually address the need for school age children who are suffering from malaria. And we basically taught the teachers to do some basic screening and providing some pills. And it was successful enough that the Ministry of Education and Health asked us to take that on as help them actually make it a national program. Since then, that has changed. The protocol for malaria treatment has changed, but it's to recognize that we were one of the first to work on this, and now malaria control in schools is more of a generalized activity in many more countries. Next slide. Next slide. You'll see, so for example, in Mali, the malaria season is different, but we recognizing that malaria is an issue among school-age children. There's now education and net distribution through the schools in Mali. That's a program that didn't exist as part of school health and nutrition 20 years ago, but is an integral part of Mali's program now. Next slide. And it also includes actual treatment, again, by the teachers. So this is an interesting piece with the changing epidemiology of malaria. Save the Children has actually adapted the program, and it's become, again, a globally recognized issue about how do you deal with malaria for school-age children? What can the schools do to prevent and even treat children from malaria in the school system? So again, those are a big change over the years. Next slide. And I wanted to talk a little bit about the school feeding. So I think we've focused very much on nutrition, about micronutrient deficiencies, about food selection, but we Save the Children's history actually goes back to where we were feeding children in the very beginning because of World War I, and it's kind of, we'll come back around and we're looking and how do we address some of the hunger issues. We're dealing with nutrition with micronutrient supplementation, deworming, diarrhea prevention through wash interventions, nutrition education. But there are some hunger issues and how are we dealing with this? So these are pictures of 3 different activities. The young girl on the left, that's us working in Malawi with ECCD centers, preschool schools, teaching parents about better nutrition and how to take local foods and actually feed younger children so they can actually benefit from going to preschools. And then the top picture on the right is children receiving school meals through USDA's food for education programming. Again, how do we take the donated food and make it nutritious and help children get the meals at the right time of the day to benefit most? And then the bottom picture is working in a context where there's no donated food, but recognizing that children do need to eat in schools, and working in Nepal where we're providing lunch pail, empty pails that called tiffin boxes that parents are encouraged to fill with some leftover food so that children have something to eat in schools. So this is activities that are actually addressing hunger issues. And this goes with the bigger global trend to look at what are some homegrown school feeding activities. I think in the past, there's been a lot of school meals that were donated and put into question the sustainability of school meal programming. But now looking at it and saying, yes, hunger is an issue, but what can we do differently so that those can be addressed through more sustainable homegrown methods? So these are some examples of what we're doing. Next. So, and for me, the most recent exciting development is menstrual hygiene management. And I will say that it's something that has really been impacted because there are more and more girls and more children going to school, but particularly more girls are staying in school to the point where they're now becoming adolescent and they're going through puberty, and something we should have been addressing earlier, but it wasn't highlighted because there just weren't that many girls of menstruating age in schools, but now they are, and we want to actually support them. So the work we're doing is, again, many different coalitions. Next slide, for example. There are many different organizations working together to see what are the elements that girls and actually their peers, the boys, to understand what is menstruation, and so that they can stay in school. They have the wash resources, they have the menstrual hygiene resources, they understand the puberty issues, and the boys are important because they are a contributor to some of the stigma and the bullying that can happen if they don't understand what is happening to girls' bodies. And so we work really closely with all the different organizations to recognize that to keep girls in school and have them actually participate fully in the classroom activities is to be able to provide them with some support during their menstruation. Next slide. And finally, one of the top killers, unfortunately, of children over age 5 are unintended injuries, car crashes, to and from school. For children over 9, it's the #1 killer. And over 5, I think it's become close to being one of the top killers of children. So what can we do to actually advocate for safe journey to and from schools? What can we do to have children wear helmets or slow down the cars? There are different activities, and this is something very new that we are trying to explore to make sure that children are actually able to get to school safely. Next slide. So I feel like I just went through a laundry list of all the exciting things that have been happening over the 20 years. And it's been exciting to see the changes, the new things we're working on and addressing different issues. Again, excited to see that we're dealing with menstrual hygiene, malaria. Those are new innovations and successes. But we continue to have some challenges. And I think all the long list of activities I just mentioned, that's part of the challenges of school health and nutrition. You look at the list of things we should be doing and to be a comprehensive programming to do the right services and health education and get the environment and getting everybody, the children and the parents involved, it becomes a very big program. So comprehensive school health and nutrition can be daunting. And it's just acknowledge that there's always an issue we have to deal with. There's a new problem that we want to address. And I started this business. I started working in school health and nutrition 20 years ago, actually addressing HIV, AIDS, and education. And how do you work with teachers to reduce stigma and to increase preventive messages that's difficult to deliver. That was 20 years ago, and that's something that we haven't talked about as much, but it's part and parcel of school health and nutrition is to provide all those different preventive messages of different health issues and nutrition issues. Again, comprehensive school health can be very daunting. So I think trying to figure out how to focus on what's most necessary and to be not overwhelmed with all the things we could be doing is a challenge and continues to be for school health and nutrition. Especially as I mentioned, there's so many things that keep on coming up that we thought we knew how to deal with something. It turns out that we need to work on something more. And then measurement. I think measurement is education staff want to know how is this impacting the educational outcome. So menstrual hygiene is a good example. I think there's been a lot of discussion about the fact that attendance has been wrongly used as a measurement for menstrual hygiene management programming. Unfortunately, it's there are girls who do miss school because of menstruation, but there are a lot of girls who do attend school without proper support. And if you use attendance or enrollment as a measurement for whether we're doing right by the girls and their needs, it's a measurement that's not accurate, and it's very misleading. We're learning that girls need more support. Girls can't participate. They may be in school, and the word participation in the education sector used to mean actually showing up at the classroom. But beyond that, actual participation, raising one's hand and being comfortable enough to participate and answer questions, that's a different level of measurement. That's really difficult. Iron supplementation is something that everybody believes, like anemia should have a direct impact on children's ability to learn. But those are measurements that's really hard to get. That direct links are difficult. So I think measurement and when you're talking about linking with comprehensive school health, those measurement tools become more complicated and more difficult. So acknowledging that single issue programming is easier, single issue measurement is easier, but when we're talking about all the different issues that we would want to deal with through school health and nutrition, it gets more difficult. And then I mentioned behavior change, and I think there are so many different ways of providing education, but we want more than just education. We want people who and children who know the facts, but actually taking change, making behavior change that will have a positive impact on their lives. And that is something that is difficult. And we are trying different methods. How do you deliver good behavior change? If you had all the money and all the time in the world, it'd be a different story. But how do you deliver that in a context where children are crammed into classrooms and teachers are feeling overwhelmed, and there's not enough hours in a classroom to deliver some of the messages beyond basic reading and writing? And so some of the behavior change messaging and methodologies need to be adapted for the school context. So that's another piece that's really difficult. So I think those are challenges that existed 20 years ago. Those are challenges I'm sure that existed hundreds of years ago when school health, the concept of school health had been around for decades. And I think these are some of the issues that still plague us. And I want to bring up some of the new areas we're also trying to address. So physical activity. When we talk about nutrition, we've been talking about double burden or / triple burden of nutrition. Undernutrition has been the classic example that we talk about, but there's also the micronutrient deficiency. And then the triple or the double part is the overnutrition. And one of the activities that we try to push for is physical activities to combat overnutrition. However, we're also working in an urbanization context. Children are going to school in an unsafe environment. So I just talked about the fact that road safety is an issue, and we're trying to increase physical activity by maybe promoting walking to schools, but walking to school could be dangerous. How do you deal with the dangers of cars and unintentional injuries when we're also trying to increase the physical activity by walking to school, for example, in many of the urban centers? How do you increase physical activity in urban centers when there's no playground, no places to have activities? So these are some challenges that are happening. And then provision of glasses and hearing aids are something that I think, most parents recognize this as something that if their child is needing glasses or hearing aids, we should be providing them, but that actually requires a specialized, individualized provision that is more costly in some of the resource poor settings. But that's something we need to do, and we're looking at, and there's been a lot of examples of governments taking on screening in classrooms. That once you do screening, how do you provide the glasses or the hearing aids? Those are new areas where you may not be providing glasses for 100% of the children, but the 5 to 20, 10% children who do need them, we need to figure out how to provide those the glasses or hearing aids. So there are some of the new challenges. Next slide. I'm going to go through. I wanted to just come back to the basics. So all those are challenges, but I think we've been working with the very consistent framework. The framework that was launched in 2000. Next slide. And it has the 4 parts, and I don't think that has changed. And I think the concept that to be healthy to learn and learn to be healthy, that is critical for the education sector and the health sector. And it's a continuing model for Save the Children for school health and nutrition in general. And it applied 20 years ago and it still applies now. Next slide. And again, the same framework and just with a little more fancier information and just expanding a little bit more, like safe water and sanitation is just not more, it's not water and sanitation, it's safe environment. So actually learning to see that there are a lot more things to consider beyond those 4 pieces in the beginning. We have increased the activities and the issues we're dealing with. And then at the bottom, just to highlight the work we have to do in partnership with different sectors, working in communities, and also making sure that children are participating. Next slide. And this is an example of how you can take one issue, in this case menstrual hygiene, and apply the 4 elements, and you can use that framework to work with any issue and actually talk about what are some of the elements that you want to be able to address. In case of menstrual hygiene, it's providing emergency pads, emergency painkillers, providing good life skills and education about puberty, having the right environment, having latrines that the girls have defined as what they need, and having good policies about having emergency kits. So those are the 4 elements, and it's addressing the menstrual hygiene element, again, using those 4 pillars. So I think what's been really amazing about working in school health and nutrition in 20 years, that the framework has been really solid and something you can use to deal with different issues. Next slide. And DCP3, disease control priorities, just came out last year, and again reaffirms that the need for addressing children's and adolescents' health and how important school health and nutrition is. So the disease control priority is a health document, but last year, they actually trended and made sure it also had an educational outcome. So again, reinforcing that anytime you do school health and nutrition, you have the health point of view, but you also need the education point of view. Next slide. And addressing so many different health issues, and there are, we've touched on most of these topics, but to just address that there are a lot of health issues, and it is context driven, and some of these issues you're going to have to make some tough choices, but there are a lot of health issues and school-age children in and out of school. We need to figure out how to address these issues. Next slide. And school health and nutrition is using the education platform. And I think the education sector has changed to the point where there's great recognition that early childhood programming is critical, and children learning the potential at younger age is great, and working with the early childhood programming is critical for school health and nutrition. A lot of the good behaviors we're talking about, nutrition choices, oral health, that's the younger you can start, the better it is, and longer lasting the impact is. So working closely with the education sector, who's also recognizing how important that early ages are, working with them to make sure that school health is an integral part of that early childhood programming. Next slide. Similarly, the reverse. So we've been talking about school-age children. I think, for the past 15 years, there's been focus on getting those primary education correct. And if you look at the data, there are more and more children in schools and actually succeeding and graduating from primary schools into lower secondary/secondary schools. So we need to look and see how we can invest in the lower secondary and how to reach, or at secondary schools, and how to reach adolescents, because that's also the next step. We can't just stop with school age at age 10 or 12. We need to actually work with the school system to address the needs of adolescents who are more and more in schools. And in the past, they have been out of school, but again, they're coming more and more into school. So working closely with the education system to go younger than 5 and then older than 12. Next slide. Next slide. And I wanted to point out that it's about learning for all contexts. I think if you look at the needs of nutrition and water and deworming, it doesn't matter whether you're in a quote unquote development setting or in an emergency setting. Those are critical pieces that all school age children, younger and older and primary school age children need in all contexts, in the humanitarian response, they still need a good quality learning environment to be able to learn. So looking at this across all contexts is an important piece. Next. I just wanted to touch a little bit on the behavior change, and I think I alluded to the fact that there's so much more we need to do, and looking at different ways of innovating and making behavior change easier. So this is just a slide from Bangladesh where we used, after the children had been getting messages, to instead of spending more time on giving more messages, actually having visual cues that actually help children remember to wash their hands by handprints and footprints as opposed to more messaging. So actually getting children to change their behavior and innovating different ways of doing so. Next slide. Again, going back, this is a 20-year retrospective, and I don't have a slide from 1998, but about 5 years into the program, you can see where some of our programming is. And these are programming where, say, the children had our own private resources to invest in school health and nutrition programming. Next slide. And then now we're taking some, in addition to our private money, we've been able to use corporate donations, government money to expand and do more programming in different parts. And I would say these are, we consider them school health and nutrition program because we're working on health and nutrition issues with the education sector, but the programs do differ. You know, in Australia, what we do is different. We're focused very much on nutrition education as opposed to maybe in Mali where we're doing malaria control. So the programs do differ, but they are using the FRESH framework, recognizing the needs of school-age children and using the two systems. And we're trying to expand these programs as much as we can. Next slide. Because Save the Children's campaign is to actually reach every last child and to make sure that every child gets quality education. And we think the school health and nutrition is part of the quality education and quality health and nutrition. Next. And we do that by a theory of change. And I think I've demonstrated some of the theory of change is that we take pilot small programs and get the evidence and actually have partners to work together to expand, to advocate, and then to scale up the program as much as possible. And I think deworming is a good example. Washing schools is another example, and so many more activities. And 20 years has gone by really quickly, and I think 20 years more will come, and we will be tackling different issues. Next. Next. And one of the way we do this is to learn from each other. One of the benefits for working for an organization like Save the Children is that we have programs all over the world, and we try to get together and learn from each other and share activities. And I just wanted to share this because one of the first things I did 20 years ago was actually as a World Bank person, I was invited to one of the learning group programming that Natalie put together in London. And at that point, there was like 10 or 15 people. And it was, people are learning from each other and sharing, and that was 20 years ago, and we still try to do that. In the last meeting, we had over 50 people at the meeting and learning from each other. And I think that's a critical piece, working for an NGO that can actually bring other people together to learn from each other. Next. So I try to rush through that so that we could have some time to have people make comments or questions. It's been a privilege to work on school health and nutrition for the past 20 years. I don't know how many more years I'm going to be working, but I have a feeling the rest of my working career will be with the school health and nutrition as well. And I've seen it's been amazing to say I've seen the changes, but also understand the challenges and see the good framework that we have to work with. So I'm going to stop there. I think there's a lot more to be said, and there's been a lot of comments, but I have not been able to read any of it. So, Mohini?
Thanks, Sung. Thanks for that journey through Save the Children's experience in school health and nutrition over the last 20 years. And there's been an awful lot, and you've covered so much of it and in this short time and given us the opportunity to listen to different perspectives from Natalie, Andrew, Claire as well. There was a question from Professor Shubhada Kanani from India, who says that in resource-poor schools with heavy workloads, what are successful strategies to sustain school health and nutrition strategies in the school system after a project phases out, or external catalysts are no longer around? Following on from that, she asks the weakest link to the national weekly iron folate supplementation and twice yearly deworming program in India is behavior change, communication. You touched on this in your presentation as well. Do you have any experiences to share? And I think you talked about the nudges, but if you could just answer to that question on the sustainability of school health.
Yes, so I think it is, I think it has been the challenge of quite a lot of our programming is to see how we can sustain activities, and it goes back and forth. Like, we've tried to work with governments to be able to hand it over to governments, and then when we come back, it's not as continuing. I think that was also alluded to. Some of the weakest point is when teachers are able to provide iron supplementation because they can do it, but to actually do the nutrition education that's necessary, it's a little bit more difficult. So I would say that is a big challenge. We've had more successes sometimes with PTAs, parents who get really involved, children who get really involved. And I think there's not a silver bullet. There's not one answer to this problem. I think one of the interesting studies that Mohini helped set up was to see what are some of the factors that allow schools and communities to actually maintain wash facilities. And it was interesting. It was a qualitative / quantitative data where we looked at a set of schools that had actually fixed wash facility that had broken. What drove them? It wasn't, there were a set of schools that had same interventions as another set of schools, but what was the difference between the two sets where the one set of schools actually took action to make changes and actually fix the wash facilities? And I know that's not quite the same thing about nutrition or whatever, but I think it's the same principle, is that what are some of the factors that once the program is over, communities take action or the schools take action to do what is necessary to maintain what the activity had been. So the case of the wash facility was interesting. Is there certain, so I think people who've done this research, it's what are the necessary components, and then what are the actual sufficient, what is the sufficient, what's the extra element that allows for that change. So what was really interesting with the wash piece was that those schools that made the change to actually take action had champions, and it's a hard concept in that you can't train some of the champions. You can't train. It's not a one person. It's not the principal per se. It can be the principal. And I do remember visiting some schools in Mali where a district education office was so fired up that he was a champion of the activities we were doing, and he tracked things. So the idea was that in that case, it was a district officer. In some places in Nepal, it's a parent who has a special interest. In another place, it's a grandparent. So it's not necessarily a person that you're assigning, but different communities have different champions. They have to have an interest. You need that, and then you also need some of the basic necessary elements, like having enough support from the education support system and to be able to actually do wash maintenance. So I know, and it was interesting, so having that person, a champion, to make sure that the resources that are available are being used. Because sometimes the resources are available, but it's not being used. That teachers who've been trained actually are pushed to do the activities. So there are different elements. And I think for me, that was a really interesting study to say, we need to figure out how to engender some of this excitement, passion for school health and nutrition in each of the communities, because even when you have the best school systems, not all schools deliver. I think it's a success if a national program is able to deworm and like 9 out of 10 schools, but the 10th school, you need somebody to push it for them to deliver that. So it's recognizing that we work with different systems to get those systems in place, but that systems do fall apart, and then we need different ways of making sure that the systems work. And I'm not sure if this is addressing that question, but I think it's different solutions for different contexts.
Thanks. So thanks for that. There are a few other comments I want to quickly read. Mario Mbede from Mozambique had a similar question around sustainability. Mario, I hope that answers your question as well. There was a question on resources for healthy food choices and physical activity to reduce both underweight and overweight. And I would refer you to the resource page for our fresh webinars, where we have several links to nutrition and physical activity from our previous webinars. I will send out the recording from today's webinar with a link to our resource page on Fresh Partners, and there's also on Schools and Health and Save the Children's Resource Center. Then there's another question around, or comment rather, about that challenge of providing glasses. And in Mali, Koulibaly reports that we do vision screening the service. What are some of the barriers, trying to address those? And then there's a comment from Jane Sherman, who says, congratulations on your achievements in relation to the comment on behavior change. The FAO paper on school food and nutrition education, which is forthcoming, believes that behavior change is not so difficult to achieve in schools if it's connected to actions and interactions with the environment, to families, and to interventions such as the range of Save the Children programs you showcased today. And lots of other congratulatory notes, Song.
Thanks. And I just realized I was going to ask Natalie and Andrew to say anything, I mean, if they had any reflections, and I just realized we run out of time. So
yeah.
Sorry about that, Natalie and Andrew, but thank you so much for joining us. Mohini, you want to wrap it up and announce the next webinar?
Yes. Thank you, Song. Thank you to all the participants. We had close to 40 people joining in today, actually 40 plus. And our next webinar is scheduled for the 15th of March, and we'll be listening to presenters from GIZ on their experience, their latest experience with Washington School's operation and maintenance. And that is a focus area, as you heard from Sung's presentation today. And we'll be sending more details about that in the invites that will come out in the beginning of next month. So do look out for that, and the webinar recording, which we'll send out shortly. Thank you for joining, and have a good evening, day, and weekend. Bye-bye.
Thank you. Bye.